Good afternoon, everyone. Thank you, Dr. Manan, for the kind introduction. Thank you, chairpersons, esteemed panelists. And it's a tough job to talk on something which is so dry, like plan evaluation in the post-lunch session where the glucose in the brain is low and you all feel dizzy. I'll try to do justice to this next half an hour where I will actually talk on how the plan evaluation in early breast cancer in the hypofractionation era works. My sincere thanks. I have nothing to disclose and there is no conflict of interest. I have used a lot of information which are available online from the trial documents itself. Sincere thanks to Professor Dr. Kamruzzaman sir and the entire organizing team for this Bangladesh Breast Cancer Conference 2025. So I'll be very quickly coming to the main topic of discussion, and when we talk about plan evaluation, these are the scenarios which we usually encounter in our clinical practice: whole breast radiation, sequential boost, simultaneous boost, external beam APBI, brachytherapy based APBI, IORT, and proton beam therapy. So I will not discuss anything about radiobiological evaluation, nodal irradiation, brachytherapy plan evaluation, and APBI, proton beam, or IORT. So these are the relevant trials when we talk about hypofractionation era, starting from the initial Ontario Clinical Oncology Group trial or the Royal Marsden GOC trial. So these are the subsequent trials: START A, B, UK fast, import high, import low, UK fast forward, Hyport ART, and Energy Oncology RTOG 1005. So a quick summary of all these trials where I have actually summarized the different arms and the dose and fractionation. So if you see the initial trials where all the control arms or the standard arms used 50 gray in 25 fractions, 2 gray per fraction, 5 days a week, over 5 weeks as standard dose fractionation, and then plus or minus boost to the tumor cavity where they used around 10 to 16 gray over 5 or 8 fractions more. Now gradually these practice actually switched towards a 15 fraction hypofractionated regime where the dose varied little bit, starting from 39 gray to 41.6 gray or 42.5 gray. But essentially the tumor, the overall treatment time remained 3 weeks, plus minus boost, and most of these trials actually have used a sequential boost where they have given another 12 to 16 gray over 5 to 8 fractions. A significant change happened of late over the previous 1 decade, where we actually see that the standard arm became the hypofractionated arm of 15 fractions, and now the comparator, so that is the comparator arm, and the new trials are actually using that as the standard arm, against which they are actually evaluating the outcome. So in the fast forward trial, we can see that the standard arm remained 15 fraction and the test arm remained 5 fractions. The initial UK fast trial actually delivered 1 fraction per week, so that you can see that the treatment time remained for 5 weeks. However, when we look at the results of UK fast forward, we can see that these 5 fractions are delivered now over 1 week. The standard arm remains 3 weeks, 15 fraction. The import high and import low, again, the divided patients depending on the risk of recurrence. The patients with high risk of recurrence, they were recruited under import high and import low. And you can see there is some significant difference in the way the plans and the doses were delivered. So we can see that in import high, the minimal dose was 36 gray to the whole breast, gradually escalated to 40 gray to the partial breast, where they have defined as the involved quadrant, and tumor bed, which is actually the tumor bed itself seen on the planning scan as the cavity or the residual, not residual, the cavity and the seroma. Now, in the import low trial, you can see that it was either the partial breast or partial breast and whole breast. That's because in the import high trial, they have actually delivered a higher dose to the site, where the investigators thought that delivering higher dose to the tumor bed will give better outcome. So you can see that the dose to the tumor bed in the import high was 52.5 gray. However, the same we can, when see in the import low, we can see that the maximum dose was 40 gray to the whole breast. And then we can also see that the partial breast that received 40 gray, that is the involved quadrant. So there are three arms in both these trials, and you can see that in the test arms, they have treated either the entire breast and then the quadrant and the tumor bed in the import high, and the breast and the quadrant in the import low trial. I am very fascinated to see this RTOG 1005 energy oncology trial because almost a decade back I formulated, also we worked on this same protocol, and we have defined this protocol in our institute that time, where we have used 40 gray to the whole breast and 48 gray to the tumor cavity, delivering over 15 fractions simultaneously. And this is an ongoing trial, Hyport ART, where the patients will be divided based on whole breast, chest wall and SCF. That is the standard arm. They will be delivered over 15 fractions. And the test arm, where they will compare this with 5 fractions following mostly the UK fast forward trial dose fractionation scheme. Interesting to see that this trial includes patients with this extreme hypofractionation dose even for this whole breast, chest wall and the SCF nodal category. That means the primary and the nodal drainage area will get similarly high dose delivered over a limited number of fractions. The benefit of, if we think why this paradigm shift happened over dose and fractionation, it all depends on the radiobiology of the breast tumor and also the surrounding tissues, which gives you the flexibility to deliver hypofractionated dose without increasing the soft tissue or the surrounding organ toxicity. So that's how the schematic representation of the import high and import low I will be showing you. So you can see that the entire breast in import high that receives 40 gray in the control arm, and both the test arms, the entire breast receives 36 gray. The quadrant of the involved breast receives 40 gray, and one arm of this received 48 gray to the tumor bed, and the other test arm received 53 gray to the tumor bed. So they have kind of escalated the dose to the tumor bed. If we see the schematic presentation of the import low, the standard arm remains 40 gray 15 fraction. And if you see here, the involved quadrant received 40 gray and 40 gray only to the involved quadrant. The one of the test arm received 36 gray to the whole breast. That is, you give little bit, so equal dose to the control arm received 40 gray. So both the test arms received 40 gray to the involved quadrant, but one of the arm received little bit lower dose to the rest of the breast, and the other arm does not receive any dose other than the quadrant itself. So it's kind of dose de-escalation, as we heard Professor Rajesh talk yesterday. He discussed all these things in the de-escalation strategies. Now, if we look at the design of dose and fractionation to UK fast forward, the control arm received 40.05 gray over 15 fractions, 3 weeks. The test arm received, one arm received 27 gray and the other arm received 26 gray to the whole breast. In both the cases, in all these cases, the tumor bed or the involved area that received higher dose with a boost, that was a sequential boost, 10 gray over 5 fraction or 16 gray over 8 fraction. And this is how the energy oncology RTOG 1005 trial schematic representation is. So here you treat the standard arm with 25 gray plus 6 fraction or 25 fraction plus 6 fraction to the whole breast and boost. It's a sequential boost. And the other arm you actually treat with 40 gray 15 fraction with a hypofractionated regime. And at the same time, you treat the boost area together like a simultaneous boost, and the dose to this boost volume was 48 gray 15 fraction. So the standard arm actually included 50 gray 25 fraction and 42.6 gray 16 fraction like the Canadian group dose protocol. Now, why do we need to understand all these dose and fractionation scheme? Because the plan evaluation will largely depend on which kind of dose fractionation protocol are you following in your institute, because if you are using 5.2 gray per fraction, that's a very, very high dose delivered over 1 fraction. So anything goes wrong, it goes wrong with a significant impact either on the tumor control or on the toxicity. Now, the principles of radiation treatment is very simple. We try to hit the target as hard as possible, and at the same time, we try to spare the surrounding normal organs as much as we can. And it's always a balance. You may not be able to make 100% to the target and 0% to the OAR. So you have to gradually develop your understanding how much you can do a trade-off. So plan evaluation is basically an understanding of trade-off between your tumor coverage and OAR dose, and depending on the situation, you sometimes may need to little bit undercover your target to safeguard the OAR if the OAR toxicity poses significant challenge in the future. So we maximize the target coverage, we minimize normal organ dose, we maximize the chance of cure by doing this, and we separate the curve, if you know that typical radiobiological curve of tumor coverage and the OAR toxicity. So we basically try to separate them out. And by doing justice to this target coverage and OAR dose, we actually we give better cure, and we are, at the same time, reduce the toxicity and with a better cosmetic outcome and functional outcome. So in breast cancer, cosmetic outcome remains a very, very significant outcome for quality of life. In most of the trials, a valid parameter or an important parameter to look for. Now, some basics are always there. How do you evaluate a plan? Now, it's not a standard or fixed process, it's a dynamic process. It varies between one tumor to another tumor, it varies between one patient to another patient, and it might vary between the same patient from today's anatomy and tomorrow's anatomy. If the anatomy changes, your entire plan will change, and your plan evaluation process will also change. So it's not a fixed thing which I can tell you that, okay, you should follow this and you have to follow that. It's a dynamic process, and you must adapt your own understanding and your institution protocol depending on one particular case to another, or you might fix a protocol under some specific research work where you can stick to the protocol and try to achieve as much as you can. So we need to know which is our target, and yesterday we discussed a lot about how to contour the breast. We discussed about contouring the primary tumor, whole breast, and also the nodes, because as I said yesterday, contouring is very, very important, because based on that the physicist will plan, and that is when your role of plan evaluation comes. So you can follow some specific guidelines which are readily available. You can follow the RTOG or the URT or the European group protocol. It's always important, as I mentioned yesterday, that you stick to one particular protocol rather than using one protocol in one patient and then other protocol in the another patient. It's important that if you are using some specific dose fractionation scheme, you stick to that particular trial protocol. Like if you are giving 40 and 48 simultaneous boost, stick to energy trial protocol. If you are using 26 in 5, you stick to UK fast forward protocol. Then it's better not to deviate. In case you are unable to follow that rigidly, then make a standard of plan evaluation chart for your department based on which kind of dose fractionation you are going to use in discussion with your physics team, depending on, because local variation is very, very significant, like your target motion, your PTV margin, everything will have some implication in dose distribution and eventual plan optimization and plan evaluation. It's always important to check the contours, the targets and OAR, and also very important to understand the critical values. And at the same time, it's very important for the physics team also to understand the basics of these targets, which target is important to us, which is what a clinician look for. Essentially what I am discussing here is basically a perspective about the clinician, but a physicist or the dosimetrist will have a different perspective. Now, it's always good to interact, that this is what I want as a clinician, and the physics team will definitely give their own understanding that this is what we feel as a physics team, that these are our challenges, and you need to come to a logical solution to every problem related to achievement of target coverage and OAR dose. It's very important to know the dose constants, but to be very frank and honest, I never remember any dose constants. I have my charts fixed on my desk. I have every protocol on my desk, so I just look at them. I never put all these garbages in my head to remember that 10 different OARs with 10 criteria I can't remember. So I remember other things which are important, but yes, you must keep all these things readily available at your working desk, so that when you are evaluating the plan, you quickly see that, okay, this is the constant we have to use. And we, as a department, in our department, what we practice, when we give any contouring to planning to a physicist, we always prepare a chart for them, that for this particular patient, this is a dose constraint I am willing to have. Now, many a times as clinician, I know that this might be difficult to achieve as per the standard, so I already deviate from the I deviate from the standard. I ask my physics team that, okay, I know this is difficult and this is what I am going to accept. But yes, I am not going to accept anything below that. So if there is a critical organ which is overlapping with your PTV, and you know that the toxicity of that high dose to the organ will make the process more complex and will threaten the life or will make some permanent damage, I am happy to accept some underdosing at that area. So what I do, I create an overlapping structure. So I instruct my physics team that, okay, fine, I do not look for 95% or 98% coverage at that overlapping area. I'll be happy to accept even 90%. Right, but I want that the OAR be saved in this particular scenario. Similarly, I tell that I don't bother about this OAR because I'm not going to have any difficult complication if that OAR is fired, but I want a good coverage to my target. So that understanding comes only when you are following some standardized protocol for a long time. You follow up your patients, their toxicities on a day-to-day basis, their weekly review, and you build up your own understanding. So you can follow either some kind of standard dose protocol like the UK consortium, or you can even follow the Timmerman, or you can follow particular trial protocol specific dose constraints. So every trial protocol will also talk about plan acceptance criteria, and as I said that it's always technique and technology dependent. So plan criteria or a plan evaluation made by a cobalt machine versus a tangent versus an IMRT and a field-in field or rapid arc VMAT and helical tomotherapy or proton will never be the same. So you need to understand what kind of technology, what kind of machine you have, what kind of gadgets you have, and accordingly you need to understand that, okay, even when the trial is saying this, I am not able to achieve, I will not be able to achieve. If tomorrow I start following RADCOM protocol and I do not have proton facility at my center, and I see that the left breast with all regional nodal irradiation including IIM, I need to achieve 1 gray mean dose to heart, I know I will not be able to achieve it because I need proton and I do not have a proton. So I have to fix my own institution specific criteria that this is what practically we can achieve, because not everyone can afford proton, not everyone can get access to proton. So it's always dependent on particular machine technology which you have in your center. Now so there are different types of plan evaluation criteria, like there is a qualitative approach and there is a quantitative approach. So a qualitative approach depends more like a visual inspection. You see the quality of the coverage, you are not typically looking at the numerical values. And that typically comes from understanding either the dose color wash or the isodose curves. You see the kind of coverage. So here we have treated like a tangent, and we can see that the coverage looks good, the dose to the lungs looks good, but at the same time when you look at the other axis, so this is an axial cut and this is a sagittal cut, we can see that there is some dark color at the edge. So this means there is some kind of hotspot. So it's also important to understand that if the dose, underdosing is not acceptable beyond a lower limit, then whether these hotspots are acceptable or not. Now typically in breast cancer, we usually try to avoid any hotspot over the skin or nipple areola complex. So say for example, I am seeing a plan and there is a hotspot sitting just right over the pectoralis major muscle, which is difficult to avoid, and if I want to avoid that hotspot that will create some kind of cold spot because my tumor bed is sitting over there, I'll be happy to accept that hotspot over the pectoralis major, but I'll not be happy to accept the same hotspot over the nipple areola complex. Similarly, if I treat a left breast and I see that the hotspot is coming toward the left anterior descending artery, I'll not be happy. I'll ask my planner that I don't want any hotspots here. I'll be happy to accept some kind of underdosing, but I need to save the heart. So please create an underdosing, give me a kind of cold coverage. I do not need hot coverage. I need a cold coverage where I want to have an uniform coverage between 95% to 100%. And if it is not possible to cover with 95% or more, I am happy to accept a 90% coverage. Because if you see, for ages, it's not for today, for decades, breasts used to be treated with tangent, with cobalt. And if you compare, if you put those dosimetry in your current system, what happens? At the extreme of the tangents, you will see that the breast is typically covered with 80% or 85%. So it's a very anecdotal discussion. So I was at CINJ, Cancer Institute, New Jersey, where Dr. Bruce Hefty was the department chair, a name in breast radiation oncology. So many a times we had this discussion that this periphery of the target is getting 85% to 90%. Are you satisfied? And that answer was very fascinating. Breast tumor is being treated with tangent for ages with 80 to 85% coverage, and it remained controlled. I don't bother. If the other parts are well covered, this is acceptable to me. But of course, that should not be our target. So once in a while, you may need to accept that, but say what I mean to say, it's not the standard you should follow, but once in a while, you might need to accept such kind of plans without any glitch. So now when we talk about the quantitative aspect of plan analysis, then there is all these indices. So you need to know what is the prescription isodose to target coverage. You need to see the Dmax. Also, the fallacy of this quantitative aspect is they give you value. They do not mention where exactly this value is arising from. So you can see that Dmax is 125%. The system will not tell you, or the numerical value will not tell you where is that 125% situated. So you have to check. So the software, you must be very well acquainted with your software. So if you see the structures on the left side, you press right button and then you will find take to the structure. You can directly go to that hotspot region. That way you can actually check any dose, like the minimum dose. You can check that immediately the software will take you to that particular slice where the dose is minimum or maximum. So you use that, check whether the Dmax location is acceptable to you or not. Similarly, we need to know the Dmean. We also need to understand the conformity index, the homogeneity index, target coverage index, and several other indices. So as a clinician, what we mainly want to see is Dmax, Dmean, conformity index, homogeneity index, target coverage. There are different other indices which are mostly important for the physicists but may not be for us. So the prescription isodose to target volume, or PITV, is the volume of prescription isodose. That means if you are giving 40 gray, then what is the volume of that 40 gray? You can actually convert any isodose to a volume using your software. So if you are having Eclipse, you can create a dose to a volume. So create the volume of 40 gray and you can check whether it is 50 cc or 500 cc or 1000 cc. And also you have the option to check what is the volume of the target. So say for example, you are treating the left breast, you can check the volume of the left breast CTV, which might be 1000 cc. And you can check the volume of your prescribed, the 40 gray volume received by 900 cc. So 900 divided by 1000, that becomes your PITV. Now conformity index is a little bit difficult. So by definition, it's the volume of the PTV getting your prescribed dose. Now there is a difference you need to understand. The volume of prescribed dose and volume of PTV receiving prescribed dose are not the same. So here we actually need to, basically we try to see how tightly the dose is hugging the target. So volume of PTV receiving the prescribed dose by volume of our isodose to target. So that's the conformity index. Now usually when we evaluate plan for breast cancer, very honestly, we do not check or calculate all these CI, HI, all these things. But knowing that will help you understand what kind of plan you are having. It is very important to understand the field placement, the PTV coverage and the hotspots. So typically the breast is treated with tangents. You put one medial and one lateral. You can have a hub beam blocker to reduce the dose to the lungs. And you can see that without any optimization, you can have a hotspot in this part because of the tissue deficiency. So you have the options of using either OH or some kind of tissue compensator to make it like a more uniform plan. So without OH and with OH, you can see that this hotspot is now removed. So the moment you put a OH, either 15 degree or 30 degree OH in the tangent, your plan quality automatically improves. Now, so when we treat with tangent, it's also important to know what is the interfield distance. So if you are having cobalt or 6 MP photon and your interfield distance is more than 20 centimeter, it may be difficult to give a good dose at the center because the contribution, the depth dose or the percentage depth dose of cobalt or the 6 MB photon is not great. So you may encounter an underdosing. To overcome that, you have to have a higher energy photon like 10 MB. So occasionally for patients with large interfilled distance, which like typically 20 centimeter or more, you may need to use 10 MB or higher dose. But at the same time, it's very tricky that do not use 15 MB because then you will have a very high exit dose. So if you put a 15 MB here, the exit dose to opposite side will be very high. So the exit dose coming from both the tangents will be significantly higher, and you can actually fire the skin with a very high dose. So be very, very careful when you are selecting your energy. Now, typically that's a contour for following like, energy 1005 protocol where we treat with whole breast and simultaneous boost. Now, traditionally when you plan with tangent, the different parameters of plan acceptance criteria also includes the central lung distance. So I am not going to define what is central lung distance, but it's desirable that you have CLD of between 1.5 to 2, which is highly desirable, but yes, you can accept up to 3 centimeter. And there is a clear-cut clinical correlation between higher CLD and pneumonitis. So we need to keep the CLD as low as possible, and if not, then you have to actually switch to a different kind of planning. So filled-in field is another acceptable technique when you plan breasts. It's like kind of a 3D CRT when you use a smaller field, a smaller tangent within a large tangent, and that also improves the conformity. Electron boost is also an accepted modality when you treat the cavity with a boost dose. However, I feel very, very insecure in using electron because it's very, very sensitive, radiation particle. Even a 1 millimeter difference in air column or even a 1 millimeter difference in thickness of the soft tissue will change your electron dosimetry altogether. So what you see on the planning software may not be reproduced on the patient. Although we know that it has a very sharp dose fall-off, so it reduces the dose to the internal organs like lungs, or for left-sided cancer, it can reduce the dose to the heart. But at the same time, my concern remains if the target or the tumor cavity sits over the pectoralis, then in any case I have to throw a higher dose through the electron, and if there is any change of position, then I'll be missing it. So I prefer more like photon, and because that's a more robust technique and there is ways to verify. You have a dosimetry, you have a planning software. So most of the centers who are using electron, they do not have an electron dosimetry or planning software. So mostly they calculate based on the depth dose profile. They calculate the depth of the target and place the beam either en face or from a different angle. But that may not be the exact thing inside what is happening. But I am sure that a photon dosimetry will show exactly what is happening inside. Now, when you talk about coverage, rapid arc or VMAT, that always gives you a better coverage. So you can see that the prescribed dose is actually hugging the entire target. And I kind of prefer this type of cold plan where I do not have any hotspots. So my instruction to our physicists remain, okay, I am fine to accept, make a plan between 95% to 107%. I do not need any hotspot. So if you plan this with simultaneous integrated boost, then you can see that actually the spill around the tumor cavity is not high. But if you do a sequential boost, the spill can be higher, because when you are planning a sequential boost, you are exhausting in the initial plan. If you are not making the entire plan together at the same time, phase 1, phase 2, then many a times you actually miss controlling this spill, because you are doing it in a phased manner, and by the time you are making the boost plan, you have already exhausted and you have not controlled the spill that much, because the initial plan looked absolutely fine. So if you are doing a phase 1, phase 2 plan, it's always advisable that you make a phase 2 plan at the beginning of the treatment and control the spill as much as you can. Now, why I prefer SIB? I prefer SIB because I always get this type of sharp dose without much spill. Because the entire plan is happening at the beginning, and the planner takes care of the entire dose constant for the entire treatment. So the plan is better optimized when you do a SIB. Now, you have to have DVH and check numerically different other criteria, like you can see when you are looking at 95% of target covered by 95% of prescription dose, or how much of the volume is getting beyond 107% dose, or how much of the volume is receiving less than 95% of the dose. So you can see all these things from the DVH. The only drawback of DVH is the DVH does not show the anatomy or anatomical area where particular dose is being dumped or underdosed. So you have to check. So you see the quantitative estimation, then go back to the qualitative estimation to check where is this underdosing. So you can play with the cursor, the color wash, select 95% to 107% to know what is the prescription dose. Then you can actually see what are the area which is underdosed or which is, then you can select 107 and beyond. That will show you the hotspot. So different combination you have to use. Now, so here I am showing you on the left side a filled-in fill technique, on right side I am showing you a rapid arc SIB technique. The triangle showing the filled-in fill and the square showing the rapid arc with SIB technique. Now this is for heart, this is for LED, this is for lung, and this is for opposite breast. So you can see in all these plans, the SIB is actually much better in sparing the OAR. So you can see that filled-in fill dose to the organs are actually higher. So this was the contralateral breast, this is ipsilateral lung, this is the LED. See the difference. So you can actually control the dose that much when you are doing SIB and BMAT. So kind of I prefer BMAT and SIB. That's the reason that a lot of dosimetric changes are there. Now there are plan acceptance criteria, which is an exhaustive discussion, and it all depends on the kind of protocol you are using. So I will not discuss the exact every protocol's details, but yes, if you look at this energy oncology, and I will show you the import and the fast forward. So these are the targets you should draw, and these are the mandatory OARs you must contour. And then there are one concept which I discussed yesterday, like you are creating the GTV, then CTV, and then PTV, and after that you need to create a PTV evaluation. You trim it off 5 millimeter from the skin, and also as per the energy you trim it off the PTV which is going inside the pectoralis muscle. So finally you get a PTV like this. So this outer circle is the PTV without any kind of trimming. So you can see that the PTV is going beyond the skin and going within the pectoralis muscle. And when you trim it off, these dotted lines, that is showing the PTV evaluation. So our concentration of dose delivery and analysis will be this PTV evaluation. So that is as per the energy criteria. And if you see, there are exhaustive discussion on how to evaluate. So there are different category like per protocol, then you have level of kind of how much variation you can accept. This is, I am not going to discuss all these things in details, but I want to show you that you have to discuss with your physics team and set a protocol that, okay, we want to follow this protocol. And together with the oncologist, even the physics team also need to read all these protocol, understand, discuss, and formulate the plan acceptance criteria. So the moment you are prescribing 48 and 40, the physics team should know that, okay, these are the things I should check during my planning. So they have given for PTV, they have given for individual organs. So and it's not very easy to achieve. And I'll quickly skip, just jump over all these because we cannot discuss all these minute things in this time. But I must request you that all these protocols are freely available, download them, and please read them to understand the plan acceptance criteria. So import highs, and if you see that all these protocols, even when they are using almost same dose, they have a different plan acceptance criteria. There is some difference in contouring between different protocols. I'll just, So import high, and then so you can so import high also gives a table of those constraints. You can just look at that. So very interesting to see the UK fast forward. Here if you can see, the control group receives, let us consider as 40 gray, and the test arm receives 26 gray. The difference is 15 fraction and 5 fraction. Now if I achieve 4 gray mean dose to heart in my standard arm and 4 gray mean dose to heart as per my test arm are the same. The numerical value remains 4, but radiobiologically it's different. So what is happening when you are achieving a 4 gray mean dose to heart in 15 fraction? You are delivering 4 gray to the heart over 15 fractions over 3 weeks. The dose per fraction to heart remains somewhere around 0.3 gray, right? When you are delivering 4 gray over 5 fraction, you are delivering 0.8 gray every fraction. So there is a radiobiological difference. That's why if you see, there is a proportional reduction of dose acceptance criteria in fast forward trial. And it's very, very important when you practice fast forward that if you are practicing 5 fraction, follow all these protocols mentioned for the 5 fraction arm. And these are the mandatory OARs you should contour as per the fast forward group. Now what I follow in my practice, I have stopped doing sequential boost for a long time, but if it is required, then I will do 40 gray 15 fraction followed by 10 gray or 12 gray depending on the need. So 10 gray over 4 fraction delivering 2.5 gray per fraction is my desired boost dose also. But most of the time what I follow 40 gray to the whole breast and 48 gray to the tumor cavity boost. And these are the OAR dose constant criteria I use, and we are pretty much stringent. If you look at our mean dose, our mean heart dose remains less than 3 gray, and it's definitely challenging, but as I was discussing yesterday, you are having a left breast cancer, probably using a different technology will help you. If we look at our acceptance criteria for contralateral lung, the mean dose should be less than 2 gray and contralateral breast dose should be less than 2 gray. If it is possible, we try to achieve even lesser dose than this. Now, to summarize, plan evaluation is a dynamic process, and hypofractionation needs special care because you are firing your target and OAR with a higher dose per fraction. It's very important to know the target, the OAR. It's very important to follow the specific trial protocol. It's very important to respect heart dose, lung dose, and contralateral breast dose, and if it is required, you may require to create some kind of underdosing to safeguard the OARs, because it's better not to fire the left anterior descending artery rather than accepting some kind of underdosing at that region. Every effort should be made to save the heart, and also skin should be prioritized because cosmesis is very, very important in any breast cancer radiation program. So a good cure, a high cure rate with poor cosmesis is unacceptable in breast cancer. We have to deliver both. We have to have tumor control and we have to have good cosmesis. So with this, I come to end of my discussion. And just like yesterday, I mentioned that if you are interested for learning precise radiation, we are equipped with variant age, tomotherapy, hyperarc, 4DCT, DIBH, synchrony. So you can write to me. We'll be very happy to facilitate you and train you, and then you can implement many things in your center also. I'm deeply indebted to all these people who have always been like a boon in my life. Thank you so much. And if you have any question, I'm happy to take.
Thank you very much, Dr. Dodul Mondal sir, because this excellent presentation against is actually is a brave to have this kind of presentation within 30 minutes, is because 30 days will not be enough to have this kind of things. So again, thank you. So if there is any question from the audience, Okay. We'll take just one or two questions because we are running out of time.
Thank you. Thank you, Dodul, for your nice presentation. You are a good academician, I know. So I don't know, yesterday you have answered this question or not, because yesterday I was not here. So again, it may be a repeat question that in the absence of DIBH, because in our country, in many centers, there are no DIBH facilities. So in the absence of DIBH for left-sided breast cancer radiotherapy, what evidence-based strategy can be employed to minimize the cardiac and lung exposure, as well as how do free breathing and alternate breath hold technique during simulation it impact on dosimetry, as well as what are the optimal contouring criteria and execution of radiation? Thank you.
Thank you, Arman Bhai. It's a very extensive question. See, it's always desirable that you should have DIBH for left-sided breast cancer, but even in our country also, not every center is having the facility for DIBH. Now, we are now blessed with so much of new machines, technologies. We do VMAT, rapid arc, randomly. We do tomotherapy. That does not underestimate the importance of a tangent plan. A tangent plan always gives you the benefit of reducing the dose to heart and lung. So what needs to be done? It needs to be understood whether the problem of tangent is you will have some cold spot in your PTV, specifically at the extreme of or at the furthest most point of the breast. So that is where it becomes very, very important to understand what is acceptable. Even if you see all these latest trials, they have a per protocol mandatory criteria and then acceptable criteria. So the acceptable criteria says that even a 90% coverage is acceptable. So there is nothing to be afraid of. Plan with a tangent that might reduce the dose to heart and lungs. Now, the moment you use a VMAT or rapid arc, what changes? It actually changes the low dose pill. With tangent, you will hardly see any low dose pill because you are using a hub beam blocker, so your lung is spared, and the part of the heart which is below the hub beam blocker is always saved. It's like zero. That does not happen with an arc or a helical plan. So it also needs to be understood then how much low dose pill is acceptable. So different studies have actually shown that 5% or 2.5, so 5 gray or 2.5 gray is a significant parameter for low dose pill. So what typically we use, we try to keep the 5 gray dose below 60% for the lungs, for the ipsilateral lung. And for contralateral lung, we are even more stringent. We try to keep it like 1 to 2 gray. But of course, you will find 1 gray or 2 gray spill all over the body when you are planning with an arc, mostly coming from the scattered dose. You cannot control that. Now, I have no experience of doing free breathing and breath hold on alternate days, because if we do breath hold, we do it for every day. There is probably nothing to believe that when you have DIBH facility, an alternate DIBH is going to give you a better outcome. So if you have DIBH, a daily DIBH is desirable because that spares the heart maximum. So if we have the DIBH facility, we'll go for a daily DIBH, nothing like alternate days. And you also asked another question like optimization. So see, optimization, it's not my territory. I happily leave it to my physics team. What I convey them what is acceptable to me. Say, for example, I am treating a left lower outer quadrant tumor. I'll be happy to accept underdosing in the left upper inner quadrant. I'll not be bothered because the typical recurrence pattern, if we see, that is within 1 to 2 centimeters of the tumor cavity. So I'll not be much bothered if the periphery or the left upper inner quadrant receives 90% or 85%. If I am able to cover the rest of the breast and the tumor cavity area with adequate dose. So that's kind of adjustment you have to make. And then there are different trials, as I have shown you. You have to fix which protocol you want to follow. Like I mainly follow the energy protocol because almost 10, 11 years back we did this study in AIIMS, New Delhi. And that 48 gray and 40 gray we have actually established that time. So back then, not too much of data was available. So there was only one article by Scorsese from Italy. But the entire study was so well conducted that the data seemed to be very, very impressive and practically doable. So the logic was, if it is doable, then you know that AIIMS Delhi is a very high volume center. And before that, our standard practice was 25 fraction, then 8 fraction. So 33 fraction, and I can reduce it to 15. That means if I can treat, 2.25 patients at the time of one patient. So that can reduce your load in the machine, and it can open up the possibility to provide better care to a larger part of the community. So that is where it conceptualized, and we started following it. And even now, I follow that particular protocol.
Okay. Thank you so much, sir. Actually, I want to add a few more words regarding this, because in our center, me, Etashamulok sir, and our colleagues, we have already done that study regarding all the lab-based patients required the DIBH. So we have done the early studies of 30 patients. Among the 30 patients, 11 patients didn't require it at all, because there is some baseline selection criteria for those patients will be the most beneficiaries. And we already published it in the Istanbul 2024. So I can share it with you, no problem about that. So thank you very much. So at this point, I would like to invite our panel of experts to share their perspectives and engage in a discussion on the topics presented today. First, I would request Professor Dr. M. Kamaluddin sir to share his insights on the presentation.